topic is pachychoroid diseases. Over to Dr. Sunil, Professor R.R. Yogian for this talk.
In fact, CME is not a diagnostic finding in any of these diseases, but CME may be there. So you are getting a pigment epithelial detachment, like here. And you are getting, so when this pressure further increases, it breaks open the retinal pigment epithelium. Now the fluid comes into the SRF and you get a classical CME. We are getting another, get fluid, but the fluid will be very minimal. And you may get in fundus autofluorescence or as an FF. So there is no gold standard for the treatment of chronic CSR. Actually PDT, because it remodels the choroid, so this is a viable option in the treatment of chronic CSR. Because this PDT is not a very safe treatment as you think, but it has got its own complications. So to reduce these complications, you have a safety enhanced treatment, that is half dose or half fluence PDT that is used. We know CSR is actually probably caused by the stimulation of the mineralocorticoid receptors in the choroid. So you can also use anti-mineralocorticoid and agents like spironolactone, so many other things, even rifampicin, all these can be used. Another common disease, that pachychoroid disease that we come across in our practice is polypoidal choroidal vasculopathy. This patient may come to you with complaining of reduced vision. When you see the fundus, you will see orangish nodules. These orange nodules will be diagnosed, this ICG angiography, which is diagnostic of this condition. You can see that corresponding to the polyps that you see, you will see the pigment epithelial defect. Corresponding to the branching vascular network, you will see the double layer sign. So this is almost like, this is diagnostic of PCV, and this should be done every case where you see orangish nodules on the fundus. And FFA will give you, if you do only FFA, you will get a finding like an occult CNVM. So these patients may have SRF, these patients have CME. CME probably is not diagnostic. It doesn't signify anything. It signifies only one thing: disease is active. So this is another patient who has been treated with multiple PDTs. You can see FFA showing the classical fluoropetal pattern and OCT showing the cystoid macular edema. So treatment should be initiated for every patient who is symptomatic and is having active PCV. And you can consider treatment for patients who are asymptomatic but active. So you can consider treatment for that, but all those with active and symptomatic PCV should be treated. One sign of active PCV is SRF. There are so many other signs. There are no internationally recognized criteria to find out which is active, but these are a few of them where you will see loss of vision for more than 5 letters in ETDRS chart, SRF with or without cystoid edema, PDE, subretinal hemorrhage. All these suggest treatment for PDT. You know, treatment for PCV. You don't know which is ideal treatment for this PCV. Many agents are being tried, an anti-VEGF agents like aflibercept, promising results. PDT can also be tried or in combination, but we don't know which is the best. Another novel pachychoroid disease where CME is seen is peripapillary pachychoroid syndrome. Here the pathology is same like the CSR. What happens is only the peripapillary choroid is thickened. So what happens? The peripapillary choroid and the choroid which is nasal to the macula but not temporal to the macula is thickened. So what will happen? The fluid will push the RP only in that area. So you will get findings only in the area between the disc and the fovea, but not beyond there is no disease in the temporal half of the fovea. So this patient, the same pathology as in CSR, but it is only seen in the temporal, only in the nasal half between the disc and the fovea centrum. If you see the OCT of the last, the findings will be same, just like fundus autofluorescence will show hypoautofluorescence, FFA will show you the window defects, and ICG will show you dilated vessels only between the macula, fovea and the disc. OCT will tell you very clearly that these pachychoroidal vessels are there only nasal to the fovea, and you see the chysis or you see the cystoid macular edema, it is only nasal to the macula, it is sparing of the retina temporal to the macula. This is again a novel pachychoroidal disease. So, so what happens now? The fluid has come into in pachychoroidal disease, the fluid has now come into the subretinal space, from there it has come into the intraretinal space. So cystoid macular edema will develop. Now this fluid will percolate into the optic disc, so that the patient will have disc edema. So there are three classical features of this disease. The patient may have SRF, patient may have intraretinal fluid, that is cystoid macular edema, patient may have disc edema. Mind you, this fluid will fluctuate by its own. Within days, sometimes the CME will disappear by its own. So you can always wait in this patient rather than jumping and treat these patients with anti-VEGF agents or any other modality. It may disappear spontaneously. The last of these diseases is focal choroidal excavation. You can see focal choroidal excavation is actually an excavation of the choroid. You see the OCT, you can see an excavation of the choroid. The patient may present with reddish vision. You may see even a neovascular membrane there. Actually, that focal choroidal excavation, what you see here is the focal choroidal excavation here. It's actually produced by the traction of the retinal pigment epithelium by the scarred choroid. But to call as focal choroidal excavation, you should not have any other disease which is likely to produce focal choroidal excavation, like a staphyloma or a scleral disease. So if it is seen isolated, that is thought to be congenital, but a patient will be symptomatic only by around 4th to 5th decade. What happens is that focal choroidal excavation actually causes the damage of the choriocapillaries. So if you do fluorescent angiogram, you will see ICG angiogram, you will see hypofluorescence. Later, the pachychoroidal vessels there will leak. So in the later phases, the ICG angiogram, you will see leak. Initially, you will see hypo, later you will hyper. This choroidal excavation actually causes damage to the Bruch's membrane and the RP layer. So when you do FFA, you will actually see a window defect there. And these patients may be associated with cystoid macular edema. So this disease is generally a stable disease. It does not require treatment. You require treatment only if the choroidal neovascular membrane develops like this. Only then you need to treat these patients. So otherwise, it's an isolated finding. Thank you.